All right, well, good afternoon, everyone. It is 12 o'clock. Fernando Holguin has got both his arms up to cheer on his faculty member. So we'll go ahead and get started. First, Happy New Year, everybody. I hope everyone had a wonderful vacation that was rejuvenating and recharging. I'm grateful to have had some time away myself, and it's wonderful to be back to really think about all the great things we're going to do this year. Our first grand rounds this year is a special one. It's from one of our very own. And I'm happy to introduce her in just a moment. I want to remind you of what we have going on for grand rounds over the next couple of weeks. Our grand rounds next week will be delivered by Dr. Daniel Goldberg, whose talk is entitled Cleo in the Clinic, the Relevance of Medical History for Present Problems in Chronic Pain Management. So it should be very interesting. On January 22nd, we will welcome Dr. Sherry Damberg, who is Chair in Healthcare Payment Policy and Director of the RAND Center of Excellence on Health System Performance. She will be talking about healthcare consolidation and its impacts. And I can tell you that this will also be a very riveting talk. So hope to see you all there as well. But today I'm pleased to welcome one of our own, Dr. Natalie Held. Dr. Held is an assistant professor in the Division of Pulmonary Sciences and Critical Care Medicine at the University of Colorado. She earned her Bachelor of Science in Molecular and Cellular Biology from Johns Hopkins. She graduated cum laude with her MD from the University of Maryland School of Medicine. We were fortunate to bring her to Colorado early in her formal postgraduate training. She completed her IM residency year, a chief year here, and then her fellowship in pulmonary and critical care medicine, all at CU. She has since joined the faculty, and from everything I hear, is a rising star in the division. She's a committed clinician educator. She oversees critical care content and is course director for the new Alpine Critical Care Curriculum, a program she developed to provide comprehensive hands-on ICU training for medical students. She's also published several peer-reviewed publications, including in notable journals such as Chest and Annals ATS. She's delivered a number of invited presentations at national and international conferences and has won multiple awards and honors, including being AOA in medical school and receiving the Theodore E. Woodward Prize in Internal Medicine. I think we're in for a delight today. Please welcome me in joining Dr. Held for her talk entitled Optimizing Cognitive Load During Rounds. Welcome, Natalie.
Can everyone hear me? Excellent. Okay. Thank you, Dr. Chopra, for that introduction. I am so incredibly honored to be here today to talk to you guys about a topic that is very near and dear to my heart, very important, I think pertinent to everyone in this audience today, which is optimizing cognitive load during rounds. My only disclosures today is that I did receive funding from our own Department of Medicine from the PACE program from 2022 to 2024. And today's learning objectives are as follows. So by the end of today's talk, you will be able to describe cognitive load theory and its application to health professions education. You will identify contributors to cognitive overload in the clinical workplace, and you will apply strategies to optimize cognitive load during your teaching rounds. And to accomplish these objectives, we'll follow this roadmap. So as one does in grand rounds, we're going to start with a case. We'll then talk about some implications of excessive workload in the clinical space. And then we're really going to spend the bulk of this talking about theory, about cognitive load theory. And I'm going to describe the theory in detail. I'm going to apply the theory to the clinical workplace, including rounds, which is my area of research. I'll then identify 4 key steps to optimizing cognitive load during rounds, and then we'll close with some future directions. Okay, so we're going to start with a case. I want everyone to imagine you are the attending on rounds. You're actually working in the ICU today. It's your first day back on service, and your team is post-call. They're going to be presenting patients that were admitted overnight. And as it's been, it was a very busy night. Your census is really long to start the day, and you anticipate that rounds are going to take a really long time. And you're already feeling a little bit stressed. You meet your team at the first patient's bedside, and you start rounds. So the intern starts. This is an 83-year-old male. He was found altered and difficult to arouse by his nurse at his nursing facility at the evening check-in. The intern goes on to give a detailed HPI. The fellow interrupts a few times to clarify some details, but he gets through the presentation and gets to the past medical history and the social history. Soon after, there's a loud bed alarm next door, and the nurse dashes away. In fact, 4 other nurses rush by, and you notice that no one's actually paying attention to the intern anymore. After a few more moments, the interruption dissipates, and attention turns back to the intern, and they move on. They start with the vital signs and the exam. Another team walks through the hallway during this, and then the intern gets to the labs. They read all of the labs since admission. The resident cuts in to add some updates from this morning, and so the team looks on while the intern is interpreting this unexpected data. Soon everyone's phone goes off. It's a secure chat sent from case management about an urgent discharge need for another patient. Everyone's signed in to this patient, and so everyone's looking at their phones. Later, a nurse stops by. She thinks her patient's ready to extubate, and so the fellow peels off. A few vent alarms are going off. And then finally, your intern gets to their assessment and plan. And they get started, they repeat the medical history, they repeat the story. And then by the time they get to their final plan, the discussion's taken 25 minutes. You don't have time for very much teaching because you have 16 other patients to get to. And so you move to the next patients. Ugh. I'm gonna pause for a second. I wanna see a show of hands. Does this feel familiar to you guys? Yeah. I just got off service in our medical ICU last week. The census has been very high. And I can say that this case came directly from my first day on rounds. The ICU is a unique environment. There's lots of alarms and emergencies, but parallels can be drawn to other clinical spaces as well. I want you to take a moment and think, what does cognitive overload look like in your role? And how does this impact you or impact the care that you provide? We can start to understand this by looking at what is known about workload or excessive workload in the clinical workplace. So first, we know that overworked providers may provide worse care. Studies have shown there are associations between high workload and things like increased patient mortality, longer patient length of stay, delayed discharge orders, increased cost of hospitalization, and an increased number of preventable adverse events and errors. And this has been shown to stay true in both the ICU and hospital ward setting. On the right, I'm showing some data from a retrospective study that looked at associations between intensivist workload and predicted patient mortality. On the top, they showed that there was a positive association between provider workload as estimated by the average bed occupancy and predicted patient mortality. And on the bottom, that the number of busy days a provider would have, which they defined as days when occupancy stayed at greater than 88%, that there was also a positive association with patient mortality. Additionally, providers experiencing high cognitive load may be at higher risk of providing care influenced by stereotypes and bias. There was an article that came out a few years ago in which authors show that medical decisions and interpersonal behaviors are more likely to be influenced by racial stereotypes for stressed providers. And this potentially leads to poor outcomes for our racial minority patients. Next, we know that high workload drives burnouts and threatens our clinician wellness. The top table I'm showing here comes from a study from Dr. Liz Harry, who was a former hospitalist here, now the chief wellness officer at University of Michigan. And her group showed that as provider workload goes up, which was as measured by the physician task load or PTL that's shown on the left and broken down further into quintiles, that as workload went up, there was increased odds of experiencing symptoms of burnouts. And our group showed that a 10% decrease in workload was associated with about a 1/3 lower odds of having burnout symptoms. And this is even after controlling for things like hours worked per week, age, gender, practice setting, and specialty. In the ICU specifically, we know that self-reported workload, job demands, and longer ICU consecutive shifts are also associated with burnouts. And clinicians with severe burnouts are shown to be more likely to leave the ICU. And then finally, we know that excessive workload threatens our academic mission. On the left, I'm showing results from a survey of academic hospitalists that solicited information on workload and perceptions of their time for teaching. What it showed was that as workload went up, that providers perceived or had a lower odds of perceiving having time for teaching and were less likely to teach for more than 3 hours per week. A similar study was done of academic intensivists, shown on the right, and similarly, they showed that as workload went up, there was lower odds of having time for teaching or feeling like they had time for teaching. And then finally, I'd like to read a few quotes from a qualitative study that was published in part by some of our CU faculty that looked at hospitals' perspectives on the impact of hospital capacity strain. And while hospital capacity strain is maybe not like the classic way we think about individual workload, I do think many of these quotes are relate and are very pertinent. So I'm gonna read these. Quote, "When you are outnumbered with patients and finding it difficult to provide the type of care that our providers want to give, that puts a strain on people and their morale and their sense of whether this job is sustainable." Or, "It definitely detracts and distracts from other things people would like to be doing, such as teaching. It can detract from taking good care of patients." And finally, "The high capacity situation has created busy days, seeing larger numbers of patients, which is just physically and cognitively mentally harder, and it creates inefficiencies." So pulling this all together, what we can say is that excessive workload is harmful in the clinical space, and it leads to worse patient care, increased burnouts, and decreased time for teaching, both in the ICU and on the ward. So we have to ask, is there an ideal workload? Like, what do we know? What is best? And in short, we don't know. There are no evidence-based guidelines out there that help us understand the ideal level of workload for an intensivist or an academic hospitalist. Oftentimes, workplace design is driven by hospital financials rather than our individual provider needs. And so here I'm showing some results from a multi-center study of ICUs that looked at associations between patient to provider ratios and the risk of having a shift with at least one patient death. And what they showed is that there was a significant, there was this positive association between ratios of greater than 14:1 with having at least one patient death during that shift. And none of the other patient to provider ratios were statistically different. So one can say maybe we should optimize our patient to physician ratios. But are there other ways that we can think about this? I'd now like to turn to cognitive load theory, which offers an alternative approach to understanding this workload problem. So cognitive load theory is a model of educational psychology that states that our ability to process information can become overwhelmed with high levels of stress on our working memory. Here, I'm going to walk you through this 3-stage model of human memory. In the model, visual and auditory information enter the mind through the sensory memory seen on the left. Information in the sensory memory is only present for a very short amount of time, in the order of milliseconds. And information here rarely reaches conscious awareness. When someone attends to information in their sensory memory, it enters the domain of working memory, which is seen in the middle. In your working memory, you process and reorganize this information so it can be acted upon or transferred to the long-term memory in the form of schema. And the schema formed in the long-term memory can then be retrieved back to the working memory during a future task to help with processing information. And this is where cognitive load theory starts to come in. The theory states that unlike sensory memory and unlike long-term memory, working memory is not infinite. And you can only process a few pieces of information and for a short amount of time. And this creates a bottleneck for processing information during complex tasks. And so we'll dive in a little bit more. Let's take a closer look at our working memory, which is displayed here by that horizontal black box. Cognitive load theory says that during a learning task, processing novel information in the working memory generates a cognitive load that impacts our task performance. And then cognitive load theory goes on to delineate 3 specific types of cognitive load that summatively fill this working memory. And that's your intrinsic load, your extraneous load, and your germane load. Intrinsic load refers to the complexity of information relative to a task in a person. So a task with high intrinsic load is one that has lots or many interacting data elements to process. Extraneous load refers to the learning environments or the way that information is presented. And so this is things like background noise or external distractions or even poor instructional design, things like a very busy slide. And then germane load refers to the process or cognitive activity spent processing information and storing it as schema in the long-term memory. And within the education world, we consider this the process of learning. But within the clinical workplace, you can also think of this as creating schema that promote clinical efficiency. And so to understand this a little bit more clearly, we'll look at an example. So we're going to talk about reading an EKG. We've all read an EKG before. So when reading an EKG, the intrinsic load is really, it's just the EKG difficulty. So an EKG where you're reading sort of a complex SVT with aberrancy is going to give you more intrinsic load than like a very traditional, simple AFib. Additionally, a more difficult EKG is going to impose a higher intrinsic load on a novice learner compared with someone who has more experience, like an advanced trainee or an attending, who's gained experience and stored schema about reading EKGs. Extraneous load is then what gets in the way of this. So when you're reading that EKG, when an alarm goes off, when maybe a nurse interrupts to ask a question, or maybe a poor quality EKG printouts. And then finally, the germane load is your cognitive processing to store schema related to that EKG, your learning. And so the foundational concept behind cognitive load theory is that when the summative cognitive load exceeds working memory capacity, your learning and performance will degrade. And so looking at this top example, you see that the intrinsic and extraneous load have combined to exceed that working memory capacity. You are in a state of cognitive overload. Learning can't occur here, and it's hypothesized that your task performance or learning performance will go down. In the bottom example, we see that the extraneous load has been reduced, making room for germane load or learning to occur. And so from an educational perspective, an ideal educational task is one in which the extraneous load has been reduced, thereby optimizing space for germane load within the limits of your working memory. I'm going to give 3 short additions to this. We have our sort of traditional understanding of cognitive load theory, but there are some additional nuances that I'd like you guys to be aware of. So first, that working memory resources can be depleted with cognitive activity and later restored with periods of cognitive rest. So for example, learning that is spaced with temporal gaps is felt to be superior to mass learning that doesn't have temporal gaps. And this is the concept of the depletion effect, or as we think of it, decision fatigue. We also know that emotions, stress, and uncertainty influence our cognitive load. So in the traditional classroom setting, these stresses are really felt to contribute mostly to the extraneous load and should be reduced. In the clinical workplace, some of these stressors are inherent to the job themselves. It's impossible to completely get rid of them, and in doing so might ill-prepare our trainees for their professional workplace. In these settings, some of these stressors may actually contribute to their intrinsic load. And so what do we do with them? The extent to which we should minimize these extraneous or intrinsic stressors should be based on learner expertise. High amounts of emotions or stress may overwhelm a novice learner, but as a learner gains experience, these stressors should be introduced in a graded fashion, and we should teach these learners strategies for dealing with these real-world challenges. And then finally, that experienced physicians capitalize on schemas and automations in their long-term memory to decrease their intrinsic load. These automatic schemas help a physician deal with the complexity that a case provides and deal with the emotions, the stress, the uncertainty that the case provides as well. Additionally, experienced physicians develop skills to reduce their extraneous load by knowing what external factors they can deprioritize. So essentially, they can sort of tune out some of that extraneous noise. So let's sort of pull this all together. It's a little bit of a busy slide, but it's a schematic where we look at cognitive load theory with the addition of these concepts of expertise development and the depletion effect. So I'll sort of walk you through this. As you move from the left to the right on the screen, you're moving from a novice learner to an expert learner or clinician. And starting in the top left of the screen, we see that the working memory, which is that horizontal black box, has been filled by the intrinsic and extraneous load provided by a clinical task. As that learner, that novice learner, gains experience and gains mental schema and automations, as well as improved information reduction or tuning out that extraneous noise, you see that the same learning task of that expert learner in the top right takes up a smaller footprint of their working memory. So this more experienced or expert learner has free space within their working memory for germane load or learning to occur. When we move from the top to the bottom of this schematic, we see the depletion effect. That is, there is ongoing cognitive activity that has depleted or reduced the working memory capacity. This is shown by those horizontal black boxes have gotten smaller in size. And so in this scenario, these learners need a break. They need a mental break. And this is even more so important for that novice learner, which you can tell is almost at a state of cognitive overload. Traditionally, we think of cognitive load theory in the classroom. But more and more cognitive load theory has been applied and studied in health professions education and in practice. In the literature, these are mostly descriptive studies, and few occur at the large-scale curricular or overall workplace level. But what we do know is that there is an inverse relationship between task complexity and learner performance in health professions education, and that there is an inverse relationship between level of training and intrinsic load. And in general, cognitive load is felt to be lower for more knowledgeable learners, lower complexity simulations, and for simulated tasks when compared with actual workplace tasks. And then finally, I will introduce briefly how we measure cognitive load, because it helps us understand how we study it. So in general, there are 3 validated domains that we can study this. None of them is considered a gold standard because they all sort of present their own positives and negatives. You can do things like physiologic measures. So while a learner is doing a task, you can measure their eye tracking or their pupil size. You can look at their heart rate, their respiratory rate variability, even brain imaging or EEG has been done. You can have them do a secondary task, meaning while they're doing the learning task, you can measure their performance on something secondary. Things like, what's their reaction time? How are they tying a surgical knot on a simulator? And then most frequently in the literature, we see people use self-reported psychometric rating scales, the most common of which is this multi-item survey called the NASA Task Load Index Survey. And to look at that just a little bit more closely, here's the NASA Task Load Index Survey. And this was a subjective workload assessment that was developed back in the 80s by NASA, but has since been broadly adapted and validated in other workplace settings. It essentially asked participants to rate their feeling on 6 subscales in relation to a task. It will ask what are the mental, physical, and temporal demands of a task, and then the learner's perceived performance, effort, and frustration. And this has been further adapted and validated for the healthcare workplace into something called the Provider Task Load Survey that integrates 4 of these 6 subscales into a summative measure of someone's workload. And I mention this because this is what I used in my research. Okay, that was a lot about cognitive load. I'd like to transition now to talk a little bit more about my research. As an intensivist and a clinical educator, I'm always struck by just how chaotic my workplace is, especially for learners. Anytime, and I know we've all set foot in an ICU, it can be a chaotic and stressful place. There's lots of studies out there that attempt to quantify this, and there was a study a few years back that showed that an alarm happens every 4 minutes during the ICU workday. But ICU rounds are really important. They're important to patient care, they're important to trainee education, and they're unique because they provide an opportunity for learner assessments and critical care education in the context of patient care. But little is known about what workplace factors, maybe these alarms, that drive cognitive load during ICU rounds and threaten our learning. So I wanted to understand this further. So between 2021 and 2022, I performed an observational cohort study where I asked, what features of ICU rounds correlate with higher cognitive load? And what I did is I observed rounds at the Denver Health and University of Colorado medical ICUs, and I recorded the events that were felt to represent the extraneous load. These were things like every time the presenter was interrupted, anytime they repeated information unnecessarily, anytime there were split attention events, meaning the team looked to multiple sources of information to gather their data, and then finally, events that deviated from the standard format, meaning the speaker drifted off script. I also measured features that were felt to reflect the intrinsic load, and these were things like how long rounds were, what the patient caseload was, how many new patients, and then how many sick patients. And I measured that by how many patients were receiving mechanical ventilation or vasopressors. And then following rounds, I had all the rounding providers take the NASA Task Load Index survey as an estimate of their workload. And I performed mixed effects regression looking for associations between these rounding factors and their cognitive load. And what I found was not entirely surprising, but interesting, that extraneous load is super common during ICU rounds. And in fact, an extraneous load events occurred every 2 minutes and 51 seconds during rounds. Each hour, when you broke this down further, there were between 8 and 9 distractions or interruptions to that speaker. There were 8.2 episodes where that speaker went off script, 1.9 times where they repeated themselves unnecessarily, and 1.8 times where when the team had split attention and looked to multiple sources of information. And then when I looked for relationships or associations between these rounding factors and perceived cognitive load, I found that it was, unsurprisingly, the frequency of these extraneous load events, as well as the number of new patients and the number of sicker patients that had significant positive associations with higher cognitive load after rounds. I then wondered, well, what types of extraneous load are the problem? And so I looked at the subtypes, and I found that it was specifically the distractions or interruptions and the times where the speaker went off script that had associations with provider cognitive load, in addition to the number of new patients and the sicker patients. I then said, well, how did these providers actually experience this? I can measure, but like, how are they really feeling these extraneous load events? And so I wondered from a qualitative perspective, what features of ICU rounds increase their cognitive load? I performed one-on-one interviews with multidisciplinary rounding providers, including anywhere from intern to fellow, the attending, the pharmacist, the dietitian, transcribed and coded those interviews, and then performed reflexive thematic analysis with a team of 4 researchers to generate 3 main themes. So first, that interruptions that break the flow of presentations drive extraneous load. That scripts and roles provide beneficial organizational structure, and that personal attributes and stressors impact our capacity for cognitive load. And I'm going to dive into each of these further with their sub-themes. So first, let's look at the broader theme of interruptions. What we found was that interruptions increase repetition and prolong the length of rounds. One provider said, quote, "When the attending interrupts, very often I feel like some of those things I would have gotten to if there hadn't been an interruption. And then I got distracted and I have trouble figuring out where I was. And then we go back to it and I'm reiterating things that I wouldn't have reiterated and it just delays." Another person said, "The more interrupted I am during my presentation, the more frustrated I become because it's like, yeah, I was about to get there, but like, cool, that's fine." And it kind of plays into your confidence, your autonomy, your trust that you want to feel as a doctor. It kind of debilitates you through the rest of your thing because you're just waiting for it again. We felt that interruptions to learners, specifically by more senior rounding providers, decrease the perception of psychological safety and reduce our ability or availability to learn. And then finally, that well-received teaching is topically relevant and avoids interruptions to a learner's presentation. One provider shared that, quote, "I like teaching that's relevant to the patient and care at that moment. Ideal rounding is whoever's presenting gets to give their whole spiel or talk, give their whole presentation, and then we talk about teaching points that are salient to patient care." So let's put this all together. It's interesting. Interruptions are one of the things during my observational cohort study that had a positive association with high cognitive load. And then in this qualitative study, we found that those interruptions had spiraling and compounding effects that affected all members of the rounding team. And so here I present to you a schematic that I'd like to call the interruption spiral. So starting in the middle, as the speaker is interrupted, this causes the speaker to deviate from the expected script and increases everyone's cognitive load as the group is trying to figure out where the speaker is and correlate that into the new setting. The speaker is interrupted and this disrupts the speaker's thought process. Data is repeated, the length of rounds also increases. Or the speaker is interrupted, this negatively impacts the speaker's sense of value. They feel decreased psychological safety and have a decreased availability to learn. So next, look at the theme around scripts and roles. How are they helpful? We found that clear and consistent role expectations reduce our cognitive load. One provider shared that just consistency, regardless of whether I like one person's style of rounding versus another, it's consistent. I think that is really helpful. It goes back to everyone knowing their role. Everyone knows what they're supposed to do. And that scripted communication corresponds with a shared mental model that reduces our cognitive workload, particularly for our learners. One provider shared that, quote, "We're all taught during medical school and during residency to think and communicate in a certain system. And so it helps me to hear an organized presentation because it's the same thought process I would have gone through." And finally, there were somewhat dichotomous perspectives on the role of repetition. Repetition, when reinforcing and iterative, was viewed positively, but unnecessary data repetition was burdensome. One provider shared that, quote, "I think repetition is helpful if it's a pertinent part of information, because then it reiterates that it's not something that should be missed." While another person shared that if something is very clear, and we've already talked about it over and over and over, the act of repeating it is just frustrating. And that just makes the day feel longer. And I don't know, it makes me want to kind of like disconnect a little bit. And it makes work feel more tedious. And then I've noticed myself getting kind of edgy and frustrated. And then finally, let's look at the role of personal attributes and stressors on our cognitive load. So we found that, not surprisingly, greater experience working in the ICU increases familiarity and confidence. One provider shared that, quote, "You do this long enough, you see most things and where most things can go. And so you can foresee certain patterns that the interns and residents don't necessarily see." We found that physical fatigue reduces our capacity for cognitive load. Quote, "I found that if I am way more sleep deprived or tired, that I have less patience for the meandering, the lack of organization." And then finally, that feeling frustrated or undervalued decreases our working memory capacity. Quote, "I'm feeling like I'm irritating someone potentially. And so I'm like, okay, this needs to be over so I can stop feeling this way." Because the longer you feel like you're irritating someone, it just makes you stressed out. And that makes the whole thing feel longer. So let's now pull this all together. Here is a schematic that shows the relationship between a state of safe cognitive load and cognitive overload. And my research suggests that it is these spiraling speaker interruptions that drives this equation over towards a state of overload. Things like clear role expectations, scripted communication, and reinforcing repetition drive that equation back towards a safe level of cognitive load. Things like ICU experience may be protective against cognitive overload, while physical fatigue and stress cause that cup to overflow. So now let's turn to some solutions. What are evidence-supported ways that we can optimize cognitive load for our clinical learners? And I'm going to show you guys some recommendations from a scoping review article published in 2018 that looked at studies looking at optimizing cognitive load in the clinical workplace. And we'll first look at evidence-guided ways that we can mitigate cognitive overload within our curricular design for specific clinical tasks. So first, we want to ensure intrinsic load is not too high or too low. So for example, you might assign patients based on their learner competence. It may not be appropriate to assign a new intern a patient with multi-organ failure or complex social needs. But as the year goes on, they develop experience, they develop illness scripts and schema that help them manage those complex patients and continue to have room in their working memory for ongoing learning to occur. Additionally, you should minimize task complexity when introducing new technologies or methods. So consider things like partial task completion for a new learner with a new task. If you're teaching someone to place a central line, consider having them go through the motor skills of vessel cannulation before having them do suturing or before having them do advanced troubleshooting. Next, standardize common tasks. So use things like checklists, standard protocols for common, complex, high-risk activities. And these are things like handoffs and sign-outs to other team. Next, what are evidence-guided ways that we can mitigate our cognitive load during teaching? So studies support teachers that remain engaged. This means limit your tangential conversations and minimize competing duties and distractions. Don't be on your phone during rounds. During the afternoon, minimize how many meetings are pulling you away from the clinical space. During a teaching encounter, whether at or away from the bedside, observe your learner's body language for hints of cognitive overload and adjust your teaching levels of support accordingly. A learner who is cognitively overloaded, maybe they have a ton of secure chats or a decompensating patient, is not appropriate for teaching in that moment, and they likely don't have space in their working memory for meaningful learning to occur. And then finally, maintain attention to learner emotion, especially during crisis situations. So we know from studies that learners who are in a crisis situation, maybe a code or a patient death, have higher cognitive load, and that their learner outcomes may be worse. In these scenarios, it may not be appropriate to do traditional teaching, but consider performing debrief with these students, augmenting reflective practices, and teaching them strategies to deal with these stressors and emotions. And then finally, what are some evidence-guided ways that we can optimize our cognitive load in your learning or work environments? And these are things that support reducing your extraneous load. So you should minimize distractions, minimize redundancies, and teach your learners to manage these distractions. Consider leveraging graphical displays rather than numerical patient data. There was a study that looked at utilizing pictorial displays of arterial blood gases and found that learners had improved identification of diagnoses and trends with those pictorial displays rather than the traditional number formats. So in this setting, I might consider utilizing the Epic graph function to look at lab trends during rounds. So we say, well, what about during rounds? These are sort of talking about our clinical environment, our teaching, but like nothing's really published in the rounding space. How can we optimize cognitive load here? What I'm showing here is a list of evidence-based best practices that came from a review article back in 2013, looking at best practices for ICU rounds. And what's really interesting about this, about these recommendations, is that many of them talk about ways that really reflect reducing your extraneous load. But nothing was studied in that context. And so they recommended things like standardizing the location, the time, and the team composition of rounds, maybe using a best practices checklist, like an ICU checklist, reducing time-wasting activities and interruptions, and then even using visual presentation of data. Other recommendations here talk about ways that you might improve the psychological safety of your rounds, which really harps back to some of the qualitative data that I presented. And these are things like establishing an open, collaborative discussion environments and promoting a team-based approach to your discussions. So how can we take these sort of evidence-based recommendations with all of the data I showed you about cognitive load to build some recommendations around improving or optimizing our cognitive load specifically during rounds? And so I'm going to present 4 key steps to optimize your rounds. So 1, start by establishing a psychologically safe rounding environment. Use introductions on your first day to set a rounding tone. Consider getting to know your learners and your rounders on a personal level and check in with them on subsequent days. Number 2, utilize a standard rounding procedure and be deliberate. And this means make expectations clear around your multidisciplinary team composition, the time and location. Who do you expect to be at rounds? Do you want the nurse present? Who should be calling the nurse before you get to the bedside? Number 3, follow a delineate roles for each multidisciplinary team member. So who speaks when? Does everyone get a chance to speak? Who's going to be putting in orders? Who's going to be updating the family? Make sure you make that expectation clear before you start rounds. Next, follow a rounding script that includes a best practices checklist. For me, this includes a very scripted, problem-based presentation that ends with an ICU checklist, but may be different for different settings. And finally, encourage a team-based approach that encourages participation. Make sure your team feels empowered to ask questions and contribute to the plan. Number 3, minimize those speaker interruptions. This is where I verbally commit to my team that I'm not going to interrupt the speaker and ask that your team does the same. Consider taking notes as the presentation goes on of corrections or teaching points that you want to make at the end of rounds to avoid those interruptions. And then finally, mind the room. So this means pay attention to your team members' body language and emotion. If you start noticing that your team is looking overloaded or tired, this is when you consider a strategic break to avoid that depletion effect. Okay, so now we're gonna go back to the original case. We're gonna rework this a little bit and apply these principles. Okay, so you guys are all going back to the ICU. Imagine you are the ICU attending on service. It is your first day back on rounds and your team is post-call and they're gonna be presenting patients that were admitted overnight. It was a busy night. Your senses are very high to start the day and you anticipate rounds are gonna take a long time. You're feeling a little stressed. Instead of meeting your team at the bedside, you're actually this time gonna meet them at the nurse's station. And you're gonna start by establishing that psychologically safe learning environment. You're gonna start with introductions. You introduce yourself. You ask each team member to introduce who they are, what their role is, maybe a rounding specific goal. You then set the rounding expectations. You might say, my expectation is that we have a scripted approach, a structured approach to rounds that is multidisciplinary. It's important that the nurse is present, and so I'd like the buddy team to call the nurse when we get to each room. You're gonna make your expectations clear around roles. So for me, I say, I want the nurse to first give some overnight updates, and then we'll let the intern present through their whole presentation, followed by the resident, the pharmacist, the dietitian, the fellow, and then it'll finally come back to me and I'll provide some corrections and teaching points. And it's important that we don't interrupt our speakers. Everyone will get their chance to talk when it's their turn. And if there is an interruption, as there often will be, and some of them are unavoidable, then we let it pass, but then we quickly go back to our rounding discussion and move on. So you go to the bedside. The nurse gives the overnight events. The intern starts to present. As happened before, that bed alarm goes off. The nurse rushes to that bed alarm, as does 4 other nurses that rush by. And you can't help it, everyone's distracted. And so you pause for a second, and then you say, hey team, let's bring this back and continue our rounding presentation. And the intern picks up where they left off, because everyone knows what to expect. Then the pharmacist, the dietitian, the resident, and fellow all weigh in. Again, we'll say that secure chat about that urgent discharge need comes in. In this scenario, you reminded your intern to forward their chats to the resident. And so in this scenario, the resident steps aside and deals with the discharge question while everyone keeps rounding. And then finally, it's your turn. You make any corrections to the plan, and then you give some salient teaching points on that patient. You keep rounding. After about 2/3 through the list, the pace is slowing down a little bit. Everyone's looking a little bit tired. And so you decide to take a strategic break for about 10 minutes before you turn back and complete rounds. Does that feel better a little bit? All right. So while many of us here attend and teach on teaching services, some of us are focused primarily on clinical work. So we have to say, do these principles apply to clinicians outside of the teaching environments? And the short answer is yes. Reducing cognitive load for our non-learners still frees mental space to allow for schema formation and automation for things that help with clinical efficiency and medical decision-making. And we know that providers that are not cognitively overloaded have improved task performance and reduced burnouts. And so finally, how can we apply cognitive load theory to future research questions? What are our next steps here? What is left to be studied? So I think there's a couple really interesting pieces here. I'm gonna start with secure messaging because I think we all experience this a lot. And I'm showing some data from a recent study that was published by some of our CU faculty group that looked at characterizing the patterns of secure chats that we received during the hospitalist workday. And while it wasn't surprising, whoa, people get a lot of secure chats. They showed that hospitalists on average send and receive 130 secure chats per day with an average of 13 per hour. And here I'm showing a graph from that article, which basically shows throughout the time of the day, when are these secure chats sent and received? And you see a marked uptick between around 8 a.m. and 4 p.m., which overlaps with our rounding time. We don't know yet how these secure chats are impacting our clinical efficiency. I think we suspect, but we don't know. We don't know how it's affecting our cognitive load. And this has yet to be studied in the ICU workplace. And so more work needs to be done here. Next, what about the electronic medical record? So we know from studies that an electronic medical record with improved usability, which is shown here by this SUS score, is associated with a lower provider task load or provider workload. So are there ways that we can harness our electronic medical record during rounds to free up working memory space to allow for better medical decision-making or more learning? And then finally, I'd be remiss not to talk about artificial intelligence. I searched for a long time. I tried to find some sort of study that looked at AI in the rounding space, and I couldn't find anything. AI has such a huge potential here, right? AI is able to compile these huge amounts of clinical data that have the potential to help us or have the potential to do some of the work that we do in preparing for rounds. So is it possible that we can harness some of these AI tools to help us during rounds to free up that working memory space to allow for more learning or better performance? We don't know how AI can be applied to the bedside, and we certainly don't know how AI affects our learners. And so more work needs to be done here. And so with that, I am going to pull this all together. Thank you for staying with me. And to summarize, I want you guys to take away that excessive workload threatens our patient care, provider wellness, and our medical education, that both extraneous and intrinsic load contribute to cognitive load during ICU rounds, and that finally, that we establish 4 key steps to optimizing cognitive load during your rounds, which is establishing that psychologically safe rounding environment, utilizing a standard rounding procedure, minimizing speaker interruptions, and minding the room. And with that, I can't finish this without a huge thank you. It is such an honor to be up here speaking today, and I would not have been here without so many people helping me along the way. Too many people to mention here, but there are a couple of names that I have to mention, which is that first, my mentor and research team, specifically Anna Newmeyer, Tristan Huey, Tim Amos, Mark Moss, Ray Pompanillo, and Ryan Peterson. Thank you to Liz Harry for being a topical expert for me in cognitive load theory. Jen Adams for her career mentorship, and finally funding that was provided by the Department of Medicine's PACE program. Thank you. I'll take questions.
Great talk, Dr. Held. We have an arm up for questions already, so I'll turn it over to Dr. Johnson.
Thank you. That was great. When you started with the case, I immediately thought of COVID-19 and the effect it had on our wards and ICU. Is there specific data about the effect that that had? And related to that, is there such thing as a post-traumatic stress where you cognitively still have dysfunction even after that environment has resolved?
Yeah, that is a wonderful question. There is data coming out of the COVID-19 pandemic about increased provider burnouts. I'm not aware of specific data about workload. Interestingly, some of these studies occurred during the time of COVID-19, so you can maybe extrapolate a little bit from that, but I don't know of any specific studies that look in that space. And when people measure burnout, it does. We sometimes look at symptoms of post-traumatic stress disease or disorder, and so I do wonder whether some of that has been shown as well. I don't know a specific study off the top of my head.
I'll ask a follow-up question on that, Dr. Held. So you talked about heuristics at the beginning, and that's obviously a key issue with cognitive load. Can you talk a little bit about how heuristics interact with intrinsic and extrinsic load? Is it helpful to have these shortcuts? Could it be harmful? How does that play out in terms of overall cognitive burden?
Yeah, I'm going to relate heuristics to mental schema stored in long-term memory. I think there's probably different ways to interpret that, but I think that the equivalent in cognitive load theory is that experienced learners have developed sort of learning or illness script shortcuts that help them process information and can handle more amounts of interacting data elements because they have these scripts, these schemas, these heuristics that help. And so from a cognitive load perspective, I actually think heuristics are quite helpful because you're getting rid of some of the extra data elements that maybe you would otherwise have to interpret individually.
Terrific. We have a question there.
Yeah, thank you so much for your wonderful talk. I think one of the questions from the chat is regarding interruptions on rounds, did your research look at other sources of interruptions other than attending interruptions with questions? Specifically, I'm wondering whether about secure chat interruptions. I find that we cannot get through a single patient presentation without several messages coming through. The trainee often feels compelled to stop their presentation. So in your opinion, is it better to consider not addressing any messages until rounds are complete?
Yeah, it's a wonderful question. So first, to answer the question about what was studied in my work. So I did not discriminate. So I recorded all interruptions. At the time of the study, we were still using pagers. And so a lot of these were actually pages that came in, but sort of similar idea. And so when I found that there was a significant association between these interruptions and cognitive load, that included everything that came in. I do think that would be an interesting study to look specifically at secure chats and something that should be a future direction here. With regards to what to do about them, it's an interesting question. I think, we can say all these things affects cognitive load, but we have to really focus on what is modifiable. Like, what can we actually do to make this better? Because certain interruptions are going to happen. Like that bed alarm is going to go off. You are probably going to get a secure chat at some points. And so I think in thinking about that, the things that were found even more importantly from an interruption perspective to be damaging were interpersonal interruptions from more senior rounding providers. So within our rounding group, we should not be interrupting each other. That was profoundly damaging. The secure chats, I do foresee, like, could you forward them to one point person? How we used to think about pagers, like, could you hand your pager to the senior residents? So I do think that's a potential outcome, but it does definitely need to be studied before we know more.
Thank you for that talk. I really enjoyed it. As someone who is undoubtedly guilty of interrupting upon occasion, so I'm going to try to ramp that down. But the model for teaching rounds has changed over the decades. When I was a younger man, rounds were sit down in a conference room away from the bedside. Admittedly, there were fewer distractions. The nurse couldn't participate, but you didn't have the patient's son or daughter hovering on every word, which I am convinced has to create a lot of stress, having the family members there. On balance, are bedside rounds better or less good than perhaps sitting in a conference room, having a more relaxed environment, and then going to the bedside for brief periods of time?
Yeah, it's a great question. This has been studied, actually. And so they've looked at bedside and table rounding, and one is not felt to be better than the other when they've studied this. I think there are benefits of being at the bedside. You can see the patient, you can see the nurse can give their updates. You know that the vasopressor doses have gone up. Like, it impacts your clinical care potentially. But then the problem of interruptions from concerned family or other things is certainly a risk. And so in short, one way is not better than the other. And I think for me, it's a little bit of an art, right? You have to be okay saying, hey, I'll circle back. Like, that's a great question. I'll circle back after rounds. But I think that there's not one good way of doing that. And it is a risk that you have at the bedside, is having those interruptions that are unfortunately only partially modifiable.
It's not just the interruptions. In my mind, I wonder if the stress on the junior learner isn't greater by virtue of the presence of the family member. And if there's a discussion that ensues and the junior learner happens not to know something, which is to be expected, does that undermine the confidence of the family in that person as a physician?
Yeah, I think you described really nicely how cognitive load theory fits in here, which is that when someone's under high stress, maybe from the family member, maybe from not knowing something, their working memory resources go down. they're much higher risk of being overloaded. They don't have room for learning and may make worse clinical decisions. And so I do think that's a huge risk. I don't know that I have the answer for it. Certainly in my practice in the ICU, we round at bedside and we do encounter patients. I round preferably outside of the room so that, somewhat less of that. But I do think that probably needs to be studied. But that, like what you described falls right into the cognitive load theory, which is that those stressors are likely harmful to our learners.
Thank you so much. I think one of the things that I was really struck by was how your experience in an environment, your familiarity really affects your capacity to carry that extraneous and intrinsic load. And I'm curious, like from your hat as someone who also like designs curriculum, if you thought about like how we should apply the schemas and your findings to the way that we approach like the cadence of training, the staffing of our rotations, because I think we all feel intrinsically that like being a first month intern in the ICU is very different than a 12-month intern, but we still have it kind of the same throughout the year. So curious kind of what your thoughts are there, if that's something you thought about.
Yeah, it's hard, right? Like some things are modifiable and some things are not. I gave the example of, for example, assigning patients based on learner experience, which sounds great. In reality, like all your patients might be sick. Like that might not be a possibility for your junior learners. And so in that sense, you might need to provide a little bit more cognitive support. You might have them do sort of partial task completion, make sure they're managing their problem of shock, and then the resident will sort of take on coming up with a plan for their renal failure. I don't know. So something like that, perhaps. I also think structured tools and scripted communication is so important here because you want to reduce as much of that extraneous load as you can from those new learners. Like when that new learner who's like already overwhelmed by that sick patient and the bed alarm's going off and the nurse is stopping by and like secure check comes in, like they're overloaded. And so as much as you can sort of like distill down, use heuristics as if possible, or, have a scripted tool, I think that will help. But to your point, it's not easy. And sometimes it's impossible to sort of mitigate some of these cognitive overload features.
A great talk, Natalie. It was really great work. I was just kind of curious, does your work look at all at attending provider variability? And what I mean by that, if you take, for example, just a consecutive 2-week time frame in the medical intensive care unit, one attending may prefer a problem-based assessment and plan, whereas someone else prefers a systems-based approach. And we are expecting learners to be really malleable in terms of their presentation styles when they're really focused on trying to learn content. And so I'm just curious how much that adds to cognitive load, because I think that's it's a very clear issue.
Yeah, that's a great comment. In short, like it definitely contributes to it. I think I showed a little bit in the qualitative study how much consistency is important. I mean, from my perspective, if I could design rounds every day in this hospital, like it would be heavily structured. It takes some of the art away from it, right? Like we all have our style that we like, and that's how we've learned to practice. And so it threatens that. But I do think from a learner perspective, that structure is so important. And in an ideal world for our learners, that we would have the same structure for everyone, which is that like everyone, follows the same problem-based scripts. Everyone has the same checklists. Everyone has the same people there. It's the same time, like really consistent. Acknowledging that, like people have the art of way they round. And so it's a hard practice to change.
Thank you, Natalie. That was excellent. So for procedural specialties like GI, I worry a lot about, particularly new fellows who are just learning how to hold a colonoscope and an endoscope, and their pagers are going off constantly. And I worry about complications, the cognitive, technical, and cognitive/technical stress that is posed on them. How do you propose we manage that?
Yeah, it's a tough one. I mean, I think as we looked at the theory that if you could reduce those, I'm going to define those like secure chats and extra things as kind of extraneous load. And in a novice learner where the intrinsic load of doing the endoscopy is already having a bigger footprint, that any extraneous load is going to like potentially push them into a state of overload. Like there could be errors, they're not learning. And so I think, we have to reduce the extraneous load as much as we can. So like forward the chats to someone else. Some of it is admittedly unavoidable. And so that's where you think like, well, are there other ways that we could also maybe minimize a little bit of that early intrinsic load? And so that's like the doing sort of partial task completion, which doesn't feel like we're used to just like having someone push through and learn. But I do think from a learner perspective, when we have all these competing things coming in, that you need to minimize the extraneous load as much as possible. But sometimes we actually have to reduce that extraneous load, which means like they're not doing the whole endoscopy. Maybe they're doing like a key portion of it at the beginning and then they sort of like build it up. But that's not the traditional way we train.
Thank you so much for that talk. It was excellent. Is there ever a damage to too low of cognitive load? When you're in a spot where something is almost too easy, if you did rounds in a completely sterile environment, is there damage there?
Yeah. So probably, there's actually not good data there. I presented some of the recommendations from that review article looking at cognitive load practices or practices that optimize cognitive load in the clinical space. And they do recommend don't make your intrinsic load too low, but they actually didn't find any studies that supported that. That was just like expert opinion. I do think though, when you think about it, we are training healthcare trainees to work in the professional workplace. And so while it does need to be somewhat of like a graded introduction of some of those sort of load features, I do think maybe day one, it's okay to have like real low cognitive intrinsic load, but like you have to introduce it. And so I do think there's a threat if it's too low that we ill prepare our trainees. But there's no data there.
The last question.
Oh, hi, Natalie. Great job. Just maybe a comment that I'd welcome your insights in, because you talked a lot about how we can control our specific grounding environment with our residents and everything else. But it seems like that there's an opportunity to improve the culture of how we interact with each other. I'm thinking about whenever we're on rounds and another team cuts through and they're having a full volume conversation and interruptions like that, unlike an alarm, which is something that we can't manage. It seems like some of those interpersonal relationships that we have with other teams can be impacted to help improve kind of the cognitive loading.
Yeah, it's tough. I think to make meaningful cultural change, you have to show that there's a beneficial outcome to it. And it is certainly annoying when a team walks through, or like, I can't tell you during my study how many times, I think this was at University of Colorado, that the like Zamboni would like go through rounds, like how many times that happened. It's wild. But like, yeah, it's a culture change. How do you get people to change what they do? And I think the only way you do that is you need everyone on the same page. Like everyone needs to believe in this. And then we also need to show that there's meaningful outcomes associated with it, which like, I think there are, but it's hard to change a culture without sort of like hard and fast outcomes that show improvements in patient care, and hopefully learning is important as well. So in short, I don't really know how to fix that. Like I walk through other people's rounds, unfortunately, because like sometimes there's no room. But I do think there has to be a cultural switch. If we want to have the best educational program here, if we want to have the best clinical outcomes, then we have to think of like the nitty-gritty minutia that impact all of that. And like one of those things might be don't walk through rounds. And maybe there's like signs in the ICU or on the floor that say that, but I don't know how you meaningful change that in such a large hospital place.
Well, one thing we don't want is an alarm to go off when you walk through rounds. That would just create more challenges. Dr. Hell, thank you. What a wonderful grand rounds. Thanks very much.